know me and what I do and how I do it. And so I'll just give you a little spoiler alert. We are going to talk about orthotics. However, that's a very small portion that's going to come at the end. Most of this is just about how you do critical thinking around how you assess patients and then how you make decisions about what to do next. So my question I asked myself, so somebody needs to mute their background. Lots of conversation there. Our focus is on this guy. So I asked myself, why are we having this conversation? Who do I want you to be able to help? And it's this guy. So I'm gonna start running these two videos. And so this guy's an athlete. You've never heard of him because he's not an elite athlete, but he's a guy who wants to be a triathlete. And if you look at the image on the left, you'll see that he actually doesn't heel strike in his right foot, and that his right leg is about half the size of his left leg. So he had polio as a kid. And so he's got all this change going on in his musculature with, hypotonicity and hypotrophy and simply not being able to function normally. So what was fun about working with this guy is he'd been getting adjusted for years. He loves chiropractic. He's been going to chiropractors for years. He was seeing the chiropractor that I bought my practice from. Once again, I'm going to ask everybody to mute themselves if they can. And so I picked him up from this other practitioner and said, listen, let's have another look. And we kept on providing him with chiropractic care. But in addition to that, we looked at his foot and his gait and, could we improve that? Now, am I going to be able to lengthen his right leg? Well, yes and no. You can do that with the lifts and that sort of thing. In his trainers, because it's very difficult to make a trainer thicker, he doesn't have an external lift on these, but he does have an internal lift underneath his right sole. So the whole orthotic is thicker. But here's the beauty of this. Now you can see that on the right side, he actually heel strikes. And the take home for him, in addition to him being happy about being able to run around in the world and do sport, it was more that he looked like he walked normally. This is his first day he wore the orthotics. He was almost in tears. So it's just about doing some thinking outside the box.
What were the symptoms that he was presenting with?
Mostly hip and low back.
Right.
Yeah. Interesting, left hip and low back. Good question.
I was going to ask you, was he compensating by externally rotating that left leg more? It looked like it was, potentially.
Yes, among many other things.
Yeah.
But yes, he was externally rotating to compensate for that. I'm looking to see if I've got people that need to come in. I think we're okay now. Right. So you all know how to take a history and do a physical exam. What I want to do is talk to you about how you might do that differently. So again, this is around thinking differently about how you approach this. So you go through your OPQRST and you're looking for things like what you see on the left. And when you hear this from the patient, you will know that they have what I'm going to refer to for this talk, an asymmetrical underlying biomechanical problem when they tell you these things. So they have a current or chronic overuse syndrome in the lower extremity, pelvis, or spine. Basically, any overuse recurring weight-bearing joint having any kind of problem. In addition to that, ask yourself these questions. Is it asymmetrical? And if so, why? Because remember, if the patient comes to you and says, oh yeah, I've got this hip pain and I started running 5 months ago and I just can't get past this hip pain, both legs have gone the same distance on the same surface in the same shoes. Why just one side and not the other? So the take home from that is the running is not causing this problem. If it was, both hips would be a problem. The other question asked is, are there other ipsilateral problems? So frequently you'll see that if they've got right hip pain, they also have medial knee pain, shin splints, and interestingly enough, oftentimes contralateral sacroiliac and low back pain. That's pretty common. So you'll also ask them about, are the symptoms worse at the end of the day or in the morning? And so as you may already know, at the end of the day, that's long-term weight-bearing activity, which causes overuse. If it's in the morning and it's more like stiffness than it is pain, it's probably more OA. And as the OA is developing, the patient gets stiffer and stiffer and more sore in the morning. Once they get going, they're much better. And oftentimes you have both. So they've got stiffness and soreness in the morning from having OA. They get up and move around in the world. They feel much better during the day. By the end of the day, they're sore again. Now they've got more soft tissue, tendon, muscle aches from trying to compensate around whatever their dysfunction is. The symptoms improve with treatment or are recurrent, and it's a presentation of acute on chronic. If so, if that's happening and the patient's coming back with the same problem month after month after month after month, you're treating the symptom, not the cause. And now it's time to just rethink it and start to look at some of these things I'm going to show you today about what to look at. Most musculoskeletal problems, overuse injuries in particular, should heal in 6 to 8 weeks with proper management of the symptoms and the causes. So if you've been seeing the patient for the same thing for 4 months, it's not a good thing. So consider that when you're working with patients. Now, that's not to say they shouldn't be in chiropractic care. So I'm going to take a little aside here and say, when you're talking about chiropractic in sports management, some of it's sports injury management, which is what we're talking about, and specifically overuse syndromes. But from a performance enhancement perspective, yes, I have athletes who get adjusted every week, all the time, because it enhances their sport. It enhances their rest. It enhances their recovery. And so they keep getting adjusted. But that's very different than treating an injury. So I'll get off that soapbox. The last thing there on the left, onset or recurrence with long-term standing or walking. So these are the patients who are working in retail or working at Bunnings or whatever, and they say that they get back pain. And they say it's because they work on cement floors at Bunnings in the shoes that they make them wear. Maybe. If that were true, everyone who walks on that floor that's about their same age and is their same gender should have the exact same problems they have. So it's not the work. It's something unique about them, and almost always, it's unilateral. So again, it's not the activity. It's what's going on in their body that's making them weaker as they go along. Trying to get the next slide to go here. Come on. There we go. Right. So that's enough about history. So if you just pay attention to that, what you're looking for is asymmetry in your history. If there's asymmetry, then you're going to start to ask your questions about, well, why is there asymmetry, right? And of course, if the patient, I don't know, is a rower and they're in an 8 and they always row port and they've got, recurring low back pain, it might be as simple as adjust them and get them to get on an erg and row starboard every day for a little while just to balance the musculature out. Those are sort of mechanism of injury, simple mechanism of injury issues. When we move on to examination, again, your exam findings should make you ask more sophisticated questions. So when you look at X-ray and you see the asymmetry here, I'm going to talk a lot more about X-ray later on, but in this case, there's a lot of asymmetry in this pelvis. We don't adjust this patient and X-ray them again. That would be nice. But you can check how the pelvis twists and rotates and tilts in your clinical experience by simply checking the leg length of the patient before you adjust them. Check it again after you adjust them. If it's changed, fantastic. It's unlikely that their leg length is anatomical if you can correct it with adjustment. So, but then the trick is, and this is what I challenge everybody to do, I dare you to do this. Check your patient's leg length, adjust them, find that their leg length balances. I dare you to stand them up and walk up and down your hallway for 1 minute and then put them back on the table, right? Because if their leg length discrepancy returns in 1 minute, you're treating symptom, you're treating effect, you're not treating the underlying cause. So you look at this picture on the lower left, that patient's got, I can't see it, it's too far away, that's a good 2 centimeters of leg length discrepancy. After I adjusted this patient, there was 0. It was even, right? That's a lot to correct, and it came right out. Now, sometimes it's just if the patients roll over and roll back again, they go right back out again. That's muscle activity. And then just in terms of things you want to do when you examine is this observation. I think this is a cool image. This is the same leg at the same point in the gait cycle in 3 different kinds of shoes. right? So look at how different the pronation is in those shoes. So footwear does make a big difference, but none of those shoes are controlling pronation in that foot. And remember that if your foot is flat on the ground on the carpet in your home, barefoot, and then you put your foot inside of a pair of shoes, the inside of the pair of shoes is also dead flat, unless it has a pretty rigid arch lift in it. But other than that, if you take the inner sole out of a pair of trainers, the inside of that shoe is dead flat. It's just like walking on the ground. Right, so we're looking at asymmetry. Now I want you to remember as we go through this conversation, because some of my former students are rolling their eyes going, oh gosh, Sherry's going on around feet again, right? But remember, the pelvis is the foundation of the spine, right? And the feet are the foundation of the pelvis. So whatever affects the pelvis is going to affect the spine. That's why we have this conversation. So there's a little list there in those funny little boxes. We're going to look at all of those things now, in particular about footwear. So what you're wanting to see in your patients, when I send out the information to my new patients, when I'm going to see them, I want them to bring 3 or 4 pair of footwear that represents what they wear during a typical week. And the older the shoes are, the better. And I tell them I want to look at the bottoms of them because I'm looking at wear patterns. So in the upper right, Andrea Dawson, can you see my cursor when I move it? Just nod, yes? Okay. I can see your face, so I'm going to ask you questions occasionally. So you can see that little blue spot on the left side, that's not supposed to be there. That's the blue that's underneath the white. It's been worn away in that one piece. In the heel, same thing. So this person's got this is their left foot that's on the reading right. Their left forefoot and their left rear foot have much more wear. In the one on the bottom, I don't know if you can see this, but the shoe on your reading right, which is the left shoe of the patient, has a circular wear pattern to it, which means that as the patient forefoot loads on this shoe, their foot twists, and they do what's called an adductory twist or a supinatory shift. As they resupinate, their foot shifts, and the stones and the pebbles in the ground actually make a circular pattern. In the lower left, again, you can see the same thing, much more wear on the reading right left heel. And the one in the upper left is the jandals or the Birkenstocks from a patient who had seen a podiatrist, and the podiatrist had added material to that sole because they thought she had a right short leg. Well, I put her on the table and adjusted her, and her leg length balanced. So unfortunately, she had to give up these sandals. We put adjusted her first of all, demonstrated to her that she didn't have a leg length discrepancy, and then took these away and had her go into better footwear. And eventually we started that way. Her symptoms got a bit better with the adjusting and the footwear, but as soon as she got away from the adjusting, her symptoms came back. So that's when we put her into orthotics. So the other things you're going to look at besides footwear is callousing. So if you look at the bottom of the patient's feet, you'll commonly see a callus underneath the distal second met, a callus underneath the distal first met, and underneath the great toe. And they'll be different right to left. The other foot won't have any, or it'll be worse. The same thing is true of bunions, which I don't have a picture of. Now this person has a little bit of hallux valgus without a bunion, but it's a funny thing. You go into any yoga class, 80% of the people there are female. Of everybody that's there, about half of them have bunions. I kid you not, half the people in any yoga class have bunions. And all of the people who have bunions, one's worse than the other. The reason they're in yoga oftentimes is because they were unable to do other types of exercise. It's the only thing they can do. So if you can get people back on their feet, the yoga is still going to be very, very good for them, but they can get more aerobic type exercise if you can get them back on their feet. So of course, the other thing you look at is just arch height. And you do that with the patient standing and sitting so that you can see, does the foot when they're standing look like it's low? And when they're sitting, it's medium or high. So that indicates that the foot is mobile. There's a whole conversation to be had about flat feet and how that happens. It's congenital for the most part. And it's also, interestingly, a little bit geographic. People whose ancestors are from close to the equator have flat feet. They usually have dark hair, dark eyes, and dark skin. The further away that you get from the equator, the higher people's arches are. So the Norwegians have these wicked high arches. That's just a little tidbit for you. Now, when you look at people's feet when they're actually standing there, you'll see lots and lots and lots of people have flat feet. Again, the first thing you're looking for is asymmetry. Are they different right to left? And looking at why is the foot overpronating, or what's collapsing, essentially. So the guy on the left clearly has dead flat feet. Now, I don't have a picture of it, but if we turn him around, his Achilles tendon goes straight up. It's erect. The calcaneus stays where it belongs. This person is what's called a forefoot pronator. So his foot collapses from midfoot forward, but his Achilles stays straight. Whereas this kid on the right, so you can see more so left than right, that there's more of a curve to the lateral Achilles tendon, and that this side is straight. And what's happening is this calcaneus is everting as she's standing there. So as the calcaneus everts, it literally pulls more on the medial aspect of the Achilles tendon than on the lateral. When people get really acute bad Achilles tendonitis and they've actually got a little squeak, or when they dorsiflex and plantar flex, if you're palpating, it goes, you can actually feel it and sometimes even hear it squeak. If you palpate really carefully, you'll find that all that squeakiness is happening on the inside, because that's where the overuse is, because this is left. Same thing is true here, but way worse on that left side. And you can see all these mid-tarsal bones bulging in much more. So these are just observational things. We're spending an hour going through this. It will take you less than 5 minutes to do this assessment of your patients, because it's all observation. So here's a patient standing, you're looking from behind, and this is a subtle thing, but it's important. From behind, you can see 4 toes on the right side and 3 on the left side. It should look like the one on the left, where you can just see the little toe. When the patient, you see more toes on one side than the other, the patient is abducting at the hip, because the ankle doesn't do that motion. The ankle moves in the sagittal plane. The knee moves in the sagittal plane. It doesn't move in the rotational plane. So it's the hip that's doing the rotation. And from that, you can conclude that they've got tight external rotators. So the patients that have Piriformis syndrome and other glute med, that kind of thing, those patients oftentimes have that foot that points out. Now, the thing to appreciate is that, yes, you can go in and you can stretch those muscles and wake up their glute med, but if you're focusing on the muscle and the tendon, you have to ask yourself, why is it tight? So again, we're going to keep asking that question, why, a lot. Here's an elite athlete who is just doing a simple squat test, and you can see that on the left, when she's standing with her legs straight, and we drop a plumb line down from the middle of her knee, that line is way over in her lateral foot. And that's because her whole torso is shifting to the left. She's balancing off of her collapsing medial arch by simply leaning to her left. When she squats, that knee goes way valgus, and now you get medial ankle stress, medial knee stress, and lateral hip stress. So she's compensating for that. Again, really simple test. Is this person functionally not keeping good support and balance from their feet up through their kinetic chain? If they do this, yes, they're compromising their knee and their hip and their back. And she wonders why she's got patellofemoral tracking syndrome and periodic medial knee pain and occasional ITB syndrome and recurring low back pain. You want to check people's dorsiflexion. This is pretty straightforward. With the patient supine, can they get their foot beyond 90 degrees? If they can, they've got good flexibility in their calf. If they don't, they've got restriction there. And you have to ask, why are those muscles hypertonic and not allowing the foot to go into dorsiflexion? This is an interesting little test most people haven't seen. You have the patient standing and you reach underneath their big toe. You're not moving the toe at the interphalangeal joint. You're moving it at the metatarsal phalangeal joint. And you try to lift the toe and you feel the resistance. So the one on the right, there's not a lot of resistance, and it gets, whatever that is, 30 degrees of extension out of that great toe, whereas you don't get any on the other side. So if the foot is overpronated, and if you look at the cursor, the plantar fascia runs from the heel underneath the arch And on the medial aspect of the plantar fascia, there's a strip of connective tissue that goes all the way out to the distal phalanx. So if the arch collapses and the plantar fascia gets tight, when this person tries to push off and extend their toe, it pulls on their plantar fascia. That's the underlying biomechanical root cause of plantar fasciitis. If you don't correct the foot biomechanics, you're never going to fix the plantar fasciitis long term. We move up to the knee. Then we talked about the squat test. You can get a valgus or a varus knee. You don't see varus knees very often outside of Texas, but otherwise you usually see men with really straight knees and women with really knock knees, and occasionally the other way around. That has to do with the fact that women's hips are built to make babies. So because our pelvises are wider, we end up with this valgus Q angle in our knees, which is going to be fine and not going to be a problem unless, in addition to that, you've got a foot that's overpronating, and now you accentuate this valgus knee. And well, I tell you, you go out and do just this simple little exam on any netball tournament, and you'll recruit patients like crazy, because there's literally thousands and thousands and thousands of young teenage girls running around on those courts with knee pain. Right, so now there's a whole lecture around what I'm going to say now, but the image on the right is a depiction of what happens in the kinetic chain when the foot collapses. You've all seen these sort of things. What I want to point out is in virtually all of the images that you see, it depicts the overpronating foot as the short leg. That's actually not the case most of the time. The foot that overpronates more is usually the long leg. So in this picture, it more or less depicts that. It's not obvious, but I'll show you. So the foot collapses, pronates, either rear foot, forefoot, midfoot, or all three. That causes internal rotation of the tibia, which causes internal rotation of the femur, which causes the ilium to rotate anteriorly. When the ilium rotates anterior, it's going to push the acetabulum downward because of the orientation of the SIJ. So the acetabulum, as the ilium rotates forward, the acetabulum moves downward, and it forces that leg longer. If you're then standing on that leg, and that long leg pushes up into that pelvis, you can see what it does to the lumbar spine. So you have, in this case, a slight, oftentimes more than that, an elevation of, in this case, the right ilium, which then tilts the sacrum and tilts the spine and gives you a left lumbar curve. That's the most common presentation of this. Overpronation in the foot, causing an ipsilateral long leg, and in weight bearing, driving that pelvis up and creating a convexity in the lumbar spine from that tilted pelvis, and then up through the spine, you get then the compensatory scoliotic curves. And again, I can talk for 3 hours on that topic. Now, when you get done taking this history and doing this physical exam, it's nice to have a way to document some of these extra things that you've done. So the recommendation that I make to practitioners is that in the same way that you might have a separate exam form for your shoulder or upper extremity and for your lower extremity for injuries, looking for ligament sprains and that sort of thing, it's also nice to have this. You all now have my email address. Actually, rather than receiving a bunch of emails, at the end of this, I'm going to send everybody some stuff. You can use it or not use it, whatever you want to do, but I'm going to send it to, so I'm going to send you an editable version of this form so that you can put your name on it and change it however you want to. But essentially, this was Nikki. Nikki came in with bilateral low back pain. This is just garden variety mechanical low back pain. I think she was in her mid-30s. And she's got a right foot problem. Underneath her second met, she's got some plantar issues. She's had x-rays, which were negative. And she has a bit of numbness and tingling in her feet and her toes. And she has a past history of right iliotibial band syndrome. And so I go through and I do the exam that we just talked about. And this is just how I notate the findings. So she has this is looking at her body from the back. So she's got a left long leg, giving her a compensatory kind of double S curve scoliosis. If it's really affecting the neck and the head, I'll make notation of that. I'd usually put another line here and another one here, depending on what the shoulders and head are doing. And then here, she's got greater left overpronation. She's got valgus in her knees. She's got asymmetrical pelvic tilt, left elevated, asymmetrical pelvic rotation anterior on the left. I didn't tick the box, I should have. A little bit of scoliosis in there. She has, I don't know if you guys can see this, she has an anatomical, a test for anatomical leg length. She does not have that. The leg length inequality resolves after adjusting. She has a little bit of too many toes, but it's pretty even, so I'm not that fussed about it. Her squat is not great, so this is mild, moderate, severe. So she has a moderate positive squat test on both sides. And her great toe is not that bad. That great toe test is not that bad. So subtle findings in subtle, these are not life-threatening problems, but it's keeping her from being active. So we started treatment. She came right. When she gets away from treatment, her symptoms come back. We put orthotics underneath her feet. We carry on with treatment for another 6-8 weeks, and then she's good as gold. Now, this is a lot. I'm not going to go through every single word of this. I'm going to, Andrew, did you have a question? Unmute yourself.
Ask, from your experience, what do you find is the best test, most reliable test for testing for an actual anatomical leg length difference?
Quite frankly, it's an X-ray of the long bones of the legs.
Oh, yeah, okay.
Right. So just to add on to that a little bit, the inter-examiner and intra-examiner reliability for using a tape measure on any part of the body in any way, the reliability is horrible.
I thought you were going to tell us there was a good way to make sure it was reliable. I got all excited.
No.
Andrea, I don't know if you can hear me, Andrea, Southern Cross do a pre-CT scan, and that gets really good reliability. So you can refer there for a pre-leg length or leg length test. Just ask for a pre-CT.
What do you call it again, Margie?
A pre-CT scan. So it's digitalized. So they're really good.
And this is one of the imaging places near you?
Yep.
Right. Yeah. That's nice to have because there's limited exposure then.
You know, they're very, very good. That's yeah, they just put, it's like before you have a CT scan, you go and get all your measurements done, and you just ask for pre-CT of the leg length.
Fantastic. Good. So if you have access to that, use that. If you don't, basically the imaging place has to have a bucky for a full spine. They put the bucky all the way to the bottom, stand the patient usually on top of some sort of solid box, and then take an X-ray from just below the bottom of the tibia up to the top of the hip. And then they give you the actual measurements. I'm going to show you an example of an X-ray report like that in a moment. Thanks for that, you guys. Right, so now what? So you've decided the reason your patient's not responding is because they have this asymmetry, and you can see all these asymmetries going on. And so what do? You start with what you do. You adjust, you do rehab, and just my little 2 cents worth, rehab should start with flexibility first. If you don't have flexibility and you start strengthening patients, you strengthen them into their soft tissue asymmetries. Then you do proprioception. When they've recovered sufficient flexibility, then I wobble them, get them doing things that are asymmetrical and get them so they have to use their brains and their proprioception to strengthen the more fine motor movements within their joints. Then we work on strength. Once you've got that, then we go into functional movements related to their occupation or their sport, and you can add, reps and intensity and stress to all of that. If you suspect that there are things going on with the feet and you want to try the simple stuff, yes, of course, you can start with footwear and you avoid high heels, narrow heels, old footwear. This is common sense stuff. But soft uppers, like Allbirds, where the upper of the shoe is all cloth, the foot moves around a lot more on top of the shoe, and it makes the whole system more unstable. We can, again, have a whole hour's conversation on minimalist footwear. The bottom line is the people who benefit from minimalist footwear are the people who are already elite athletes and have little or nothing in the way of biomechanical weaknesses. It's the people like my father who saw everybody going barefoot running and got his barefoot shoes because he could and went out on the streets and ended up with a stress fracture. So the minimalist shoes are really for a very, very, very small portion of the population. And there is, last time I looked, which wasn't that long ago, there is not one single study, zero, none, that say that minimalist footwear strengthens your feet in any way. When you combine them with training techniques for increasing your speed, doing your speed work, there's a little bit there that they might be helpful. And then when you're choosing your footwear, you want to choose high quality footwear and sandals. Got to get people out of jandals. They've got to have something more substantial in the summer. Well-fit footwear, of course, and something that's comfortable so people wear them. Now, in terms of orthotics, this is where I want to spend a little bit of time with this one. Yes, of course, you can go with over-the-counter orthotics. What you have to appreciate about that is that they are an arch support, full stop. They are not a biomechanical advice. They're a simple arch support, because you can't sell something over the counter that has either medial or lateral postings in the rear foot or forefoot, because everybody's different and they hurt people. So a simple over-the-counter device is really good for that patient who has their first episode of shin splints or plantar fasciitis that's relatively short-lived. It's only been going on a few days or weeks, maybe a couple of months. Treatment, a simple over-the-counter orthotic for 50 or 60 bucks from one of the shoe shops, and the treatment probably should take care of that. If it keeps coming back, then you know that that's not the solution. They need something more sophisticated. We're going to talk about podiatric orthotics. I put these in their own category because of, at least in this country, my experience of how podiatrists work. I have to say to begin with that if we didn't have podiatrists, we wouldn't have orthotics. So God bless them for doing that. However, we need to appreciate that it's the very rare podiatrist who has any kind of working knowledge above the ankle. And so anytime you put any device under anyone's feet, you are going to affect every single weight-bearing joint in the body. You and I can understand that. The osteos and physios to a large degree can understand that. The podiatrists just don't have the training. The ones that do have spent a lot of time in hotels going to seminars, learning about all of that. The other thing is that when they provide the orthotics, if there's a change in the knee or the hip or the spine or the pelvis, they can't put their hands on people and do anything about that. So when they put an orthotic underneath the patient and the patient says, well, yeah, my foot's better, but now my hip hurts or my back hurts, they adjust the orthotic instead of thinking maybe they got the orthotic right and the patient just needs to have their body looked after and have some adjustments to the body. So the podiatrists are focusing on the foot. They don't address the kinetic chain. The devices themselves from the podiatrist, for the most part, are either rigid hard, you can't move them at all, or they're really soft, which means they're not very durable. So even if they get it right, the orthotics break down. The rigid orthotics, you just have to think about the fact that the foot has 26 bones. If God wanted you to have a foot bone with an arch in it, you would have one. Instead, you've got 26 bones that have to move relative to each other. And they just collapse like a bag of bones, and then the muscles cause them to become rigid again as you push off. So whatever you put underneath the feet has to move with the feet and not stop motion, but control it. They rarely, if ever, do any forefoot posting, which is another long topic to talk about later. And their follow-up care, because they can't attend to some things, is oftentimes insufficient. So when your patient is not responding to an over-the-counter device, or they're not using a podiatric, getting help from a podiatric device. Oh, one more thing about the podiatric devices, they're almost always massive. They're huge, clunky orthotics, and they only fit in people's trainers. So here's one of the clinical pearls, the take home from today. If your patient needs orthotics of any kind, they need them underneath their feet every single moment that they're standing up. Now, you say that to the patients that way so they get the importance of it. Of course, if you go 10% of the time without orthotics, nobody dies. But if you wear your orthotics in your trainers and not during the week at work, you've just missed it. So the patients need orthotics for all of their footwear so that they can keep including footwear in their house if they need it. And that's something you have to coach the patients through. So in terms of custom functional devices, they're oftentimes based on more specific and and sophisticated analysis. They're made of better materials that are more functional and durable. And there are more and more chiros, physios, osteos doing this kind of work who can understand how what they're going to do in the foot is going to affect the rest of the body. A really nice environment to be in is when you've got an open-minded, clear-thinking, critically thinking podiatrist who's under the same roof with chiropractors, osteopaths, physios, so that they can put their heads together and make something happen. That's oftentimes a really great environment if everybody's open to learning. So that's my 2 cents worth on that, the politics of that. Right. So gait analysis is done in lots of different ways. This is one sample of it. What I should have said at the beginning is I'm really clear that this is not a commercial opportunity for anybody that I know or for me. I'm just telling you what's what. So I'm not pushing anything here. This is a sample of it. The guy in this picture is a really lovely chiropractor from County Cork, Ireland, who's a very good friend of mine. And so your whole way assessment is insufficient because, for 2 reasons. One, it happens too fast for you to see. So unless you have looked at hundreds of hours of slow motion video, you're really not going to see what's going to go on in the foot and know how to create correction either through adjustment or assessing whether it's anatomical or functional or any of that. So you really need to be able to slow things down. So when you've got a pressure plate system that allows you to see how the foot is moving from heel strike to toe off in terms of the rate and the magnitude of movement throughout the foot, you get a much higher quality of information to then inform what you're going to do next. This is the kind of data that comes out. The charts and graphs end up being really great patient education tools because you can show to them, look, your left foot and right foot look like they belong to 2 different people. So that's why your back is hurting. So we need to address this. Then the numbers come out. The numbers are what are used in this particular system to post the orthotics. However, if you know what you're doing, you can just take this information and make your own decisions. Or in this particular case, you can just send the data and say, make me orthotics for this patient. Here's what's going on for them clinically. And then that produces orthotics. So here's the thing about orthotics. An orthotic is not an orthotic, right? They're custom shoe inserts. They don't stop motion. They control the rate and magnitude of pronation. In doing that, they support the entire kinetic chain, and they need to be durable and comfortable. If they're not comfortable and functional working in the patient's footwear, they can't wear them. So they can't get the benefit from them. The 2 most important factors that dictate the quality of orthotics, so when you're looking for who you're referring to, what you need to look into is how specific, the specificity of the prescribing of the posting based on a detailed and thorough clinical assessment and gait analysis. So if the person doing orthotics for you is having the patient put ink on the bottom of their foot and walk across a piece of paper, and then they're getting an orthotic off the shelf and putting that in the patient's shoes and charging them $250 for that, you might want to rethink that. That's pretty simple, right? Not going to give you lots of detailed information. The other thing, the next most important thing is the quality of the materials so that you have something that's functional, comfortable, and durable, and it moves. So an orthotic is supposed to move with the patient's foot, and it's supposed to dampen or minimize excessive magnitude and rate. So if the foot's moving too fast, the orthotic should slow it down, not stop it. If the foot is moving too far, it should minimize that magnitude of movement. We're getting there really close, so there's time for questions. The other thing is that an orthotic is not an orthotic. So a sport orthotic for general orthotics is different than an orthotic that's specifically for running in a straight line for a long time, which is different than a skating orthotic on which people are never heel striking. They're always forefoot loaded when they're on a board or a blade. For footy shoes, which are always too tight for the athlete, they've got to be skinny and narrow to get them into the shoes. For golfers who are going to walk long distance but still have to have lateral sway control. And then for the different kinds of footwear. So dress shoes like at work for a man, fashion orthotics for a woman. And then the geriatric population, the materials that these orthotics are made up should be very different, much more forgiving than they are for somebody who's young. We just said all that. Right. So in terms of outcomes, the reason, so I'm a Gemini. That means my attention span is as long as about a 5-year-old child. And I don't do the same thing for very long. Any of you who are my students know that I only lasted at college for 2 years because I needed to do something else. So I keep moving along in my life and I do lots of different things. This has stayed with me because of the people in these photos. So everything from this is a very old photo. Guy still didn't have any gray hair then. This is part of the British cycling team. One of my golfing patients. This is Portia Bing, who is a track athlete for New Zealand. Jennifer Hunt is a golfer. And this is one of my high school athletes. This is Marg, you'll know that person. That's Dr. Robinson. And then this is one of my weightlifting dudes. But also this little family, the O'Connells. And Ashling. So Ashling is somebody who is challenged by a congenital neurological condition. I'm not going to fix that, but orthotics have kept her walking. She was about to stop walking, and we got her walking. Unfortunately, over her very short little life, the surgeons have fused most of the bones in her feet. So rather than supporting those loose joints, they fused them. But the little bit of help that I could give her has kept her on her feet, which has made a big difference in her life. Righty-ho. Cool. So you might want to unmute yourself and just holler out. I'm going to go back to the other. Can I do that?
I have a question.
Yep, go ahead.
I'm going back to the very start. You had the one with polio, so it was pretty obvious why there was a leg difference there. In the other case that you described, it showed a picture of the leg asymmetry, and then you said it resolved with the orthotics. What
Yes.
attributed to the leg asymmetry in the first place?
Right. So let's talk about that. You're going to have to imagine this in your head. I'm trying to, because it'd be nice if I had my hands. I'm trying to stop sharing the screen. Stop share. There we go. Great. Right. So if you all just kind of close your eyes and think about this. If the right foot overpronates and the tibia rotates internally and the femur rotates internally, and the soft tissues around the hip rotate that hemipelvis anterior. And if you imagine the orientation of the acetabulum to the SIJ, when that right ilium rotates forward, the acetabulum rotates down. So in a suspended environment, not weight bearing, suspended, when that ilium rotates forward, it makes that leg longer. And that's what you see on the table. The patient's non-weight bearing laying on the table and their right leg is long. When you stand them up, then their right hip is elevated because their right leg is long functionally, and now their right hip is elevated, and now they get curvature in their spine. So when you start asking the why questions, here's how this goes. Your patient has 5 years of chronic recurring low back pain. They come to you and say, I've seen 2 chiropractors, 5 physios, my GP, I've seen a surgeon, they'll fuse my back, but I don't think I want to do that. Can you help me? And you say, look, you've got a leg length difference, and after I adjust you, your leg length balances out. Right. So that's going to then cause an overuse syndrome over and over and over and over and again, and that's where OA comes from. So when the foot's overpronating and you get all that asymmetry, once you adjust, it balances. As soon as the patient stands up and walks up and down the hall for 1 minute, that adjustment is gone and the pelvis rotates again. So that's how you get the long leg. Now, why is that there? So I've got low back pain. Why do I have low back pain? Because my right leg is long and my right pelvis is perpetually rotating forward and jamming up. So now just put yourself inside the facet joint of L5S1 on the right. You're inside that little joint. And the ilium is now being driven superior, jam into that joint, and it's being rotated anterior. So there's torsional stress and compressive stress through that little L5S1 joint. If that happens repetitively for 40 or 50 years, arthritis. Furthermore, now put yourself inside the disc at L5S1. When the ilium rotates forward, the sacrum has to go with it. So the right sacral ala rotates forward when the right ilium rotates forward. And in that, it then puts a torsional stress through the disc. And you start to break down the annulus of the disc, right? And that goes on for 30 or 40 years. And then your patient bends over to pick up a towel in their bathroom and blows a disc. Did picking up a towel cause them to blow a disc? No. The disc was on the verge, and all it took was that little bit. If that patient had had all of that identified when they were 10, and that got corrected when they were 10, they wouldn't be in the state that they're in, which is why I really encourage you to look at kids with this, right? So we're going to go until 3 o'clock because that's what we're supposed to do. I have a bunch of cases prepared. Anybody who wants to stick around and look at cases with me, we can do that. But we'll keep taking questions. But Rob, did that answer your question?
Yes and no. Yeah, I get the whole biomechanical outcome of what's been described there. My question was, why was the one leg different to the other leg in the first place?
Ah, right. Thank you. That's where I was going, but too much marijuana in high school. I forget my train of thought. So now you know that you've got low back pain because one leg's longer than the other. Why is one leg longer than the other? Because your foot pronates more on one side. Why does your foot pronate? It took me forever to figure that out. I don't really have any proof, but I hope to do this before I die. What I know for sure from my experience is that it's a congenital anomaly with regard to the shape of the tarsal bones in your foot. So the analogy is like vision. My right eye is worse than my left eye. I have my vision from my dad. My glasses are different right to left. My right foot has more forefoot pronation than my left. And so that asymmetry in my eyes is very similar to the asymmetry in my foot. And the reason that I'm so confident about this is because I've been in practice long enough to have seen 3 generations in the same room with the exact same foot function. Jason's smiling and nodding his head. He's seen this too, because Jason and I have been working together for 4 years. So when you see mother, daughter, grandma, when grandma comes in, the light bulb goes on, right? And so when I see the patients with big bunions, so is it your maternal grandmother or your maternal grandfather that has bunions? Oh yeah, granddad has horrible feet. You got your feet from granddad. So it's a congenital problem in the shape of the tarsal bones that then dictates that the one foot is biomechanically weaker due to the shape of the bones. This is why adjusting doesn't work by itself. Now, so if the foot's overpronating, what you're going to typically get, to give you an example, is an inferior navicular. So you're going to put the patient on the table, you're going to adjust that inferior navicular, and you're going to make that joint mobile again. Fantastic. All their functional tests are better. Fantastic. If they come back 3 days later and the foot's subluxated again, right? And so it's not about adjusting. It's also not about muscle weakness. So people don't get flat feet. It's that they get a foot problem. They suddenly notice their feet and they go, oh, look, my feet have fallen. You don't get fallen arches. You've always had an overpronation problem. That's why you will see bunions in 10-year-olds. If you look for them, you'll see them. But you will never see a newborn with bunions. So you don't get born with a gene that says, make my toe bend that way. What happens is you get born with tarsal bones, mid-tarsal bones, that are not the right shape. That little foot pronates over and over and over again. And then they get to 30 or 40, and it's tough to buy shoes because now their foot's so wide because they've got a big bunion. And they think, oh, my arches have fallen, right? They've always been falling. Did I get there, Rob? You're muted.
Yeah, that's an interesting idea. I have seen merit in that. I also have another idea.
Yeah, tell me.
And it's not always consistent as far as, actually it's actually very consistent, but it fits very nicely with your pelvis understanding. But instead of the long leg, I look at the short leg and I relate it to the abdominal function.
Yep.
So I've found different ways of testing the abdominal muscles, and I'll find a posterior or a positive Dera field on the side of the abdominal dysfunction, which will cause the exact same pattern that you're describing, but to the other leg, which will very often affect the muscles of the quad and the calf, which can therefore make the feet drop, which will create the overpronation.
Right. So there's one, and I don't mean to pick on you, but I've been thinking about this for 50 years. The flaw in that thinking is it's not a chicken and the egg. So I understand if you then correct the abdominal musculature and you work on that with adjusting and trigger point and stretching and all the things that you do, muscle energy, whatever it is you do to balance the pelvic and the abdominal musculature, fantastic. And yes, that'll help the rest of the kinetic chain. But why are the abdominal muscles not balanced and strong in the first place?
Good question, and I've thought of that as well.
Yep.
So most commonly it comes back to habits or to dominant use. So for example, if you're a soccer player, you tend to kick with one foot or the other. So you'll plant on one leg and kick with the other. So it'll use your obliques and transverse on the one side and then more the erectus abdominis on the other. If you're a parent, you might carry your child more on one side. Maybe you pick up your school bag or your briefcase more on one side, which will create these imbalances as well. And then also the major thing, I think, is that it can be related to not knowing actually how to look after those muscles, because those muscles have no structural support. So they're very easy to agitate. And this is why I was curious about that scoliosis paper that you threw in to see whether it addressed that. But you kind of just touched on it, because I believe that the scoliosis pattern is often indicated because of the abdominal dysfunction to the other side due to having no structural support. So you'll see a left lumbar convexity, and the muscle that'll fail most commonly will be the right abdominals because there's less structural support on that side.
Yep. So I totally agree with you there. And in the circumstance where you've got a soccer player who's playing enough soccer that they're doing that movement enough times that it creates that muscle imbalance, this is where if you're doing sport chiropractic and you're seeing those sort of rowers and kickers and throwers and those people who do have that sort of asymmetrical dominant pattern, and oftentimes, you're absolutely right, oftentimes you address that, show them how to bring more balance through adjusting and through stretching and exercise, and the problem resolves. Fantastic. When you start looking at scoliosis,
So it's
go ahead, Margie.
Oh, sorry, I was just going to say, often do real-time ultrasound. It's really good to get their feedback mechanism to actually, so they can actually figure out when they're actually engaging a muscle, because a lot of this they've never done. They've never engaged, so it's inhibition neurologically, and so they've never done it, so they actually don't know how to turn the muscle on. Right.
Yeah, that's very true of most people. And so when you take this conversation outside of that elite athlete, and now you've got somebody who's, does simple things for fitness and they've got scoliosis, it's probably not from overuse from asymmetrical movement that's repetitive. It's from something else. And with regard to the patients who are trying to learn what Margie was just saying, learn their muscles, if you are identified, this is where we are unique as sports chiropractors in our ability to do this. Because Rob, you can look at that and say, okay, I think this is a muscle imbalance. I'm going to look at correcting the muscle imbalance. And if that works, which means the condition or problem or imbalance that the patient came to you with resolves in a matter of weeks, because if you can get them to train properly, which is a big if you can get them to train properly, you can get them out of that. If that works, fantastic. What I'm talking about is the athlete who comes back and says, yeah, I was really good until I was in the off season, and then everything came back because I wasn't doing my exercises. So my theory is, if you have an inherent muscle imbalance because of some sort of repetitive asymmetrical motion, if you correct the muscle balance and you educate your patient, that should not return.
Agreed.
Right? If it does, they're either not being compliant, or they need a little tune-up, or you need to look at their leg length again and see if that's coming from the ground up or from the musculature down. But I got to tell you, Rob, this is great, because I've had this conversation with 100 physios, and you're the first person to articulate that argument in a way that I understood. Thank you.
Appreciate that.
Yeah.
Cherie, can you hear me?
Yes, I can.
Yeah, Colin here.
Hi, Colin.
Just recently, I've been finding that if I measure the leg lengths lying down and I measure the malleoli and they're even, and then I look at the bottom of the calcaneus and they're asymmetrical. So do we measure the length of the leg at the malleoli, or do we do it at the heel? Because I'm now thinking that there could be asymmetrical sizes between the sides in the talus or the calcaneus.
Yep, you've got that spot on. That's a really great observation and a great question. The main reason you get a difference in the when you look at the bottoms of the heel pad is usually because there's a difference in the fat pad on the heel, or because of a varus deformity in the subtalar joint. There's a little bit of inversion of that heel, and it makes it look shorter because it's inverted. And so what a lot of chiropractors do to prevent that is they really evert the heels when they look at their leg length, which is fine, but then you're distorting lots of other things. So in my opinion, if you're looking at leg length, you look at the malleoli. But if you're seeing that, that's a great observation. There is a chance that there is an asymmetry in the size or shape of the calcaneus. But I would think that amount of difference would be a relative rarity. Whereas seeing a difference in leg length between the malleolus and the bottom of the heel pad is pretty common. So you have to suss out which it is.
The other thing, just while we're on it, I wonder how many chiropractors in the field, when they have a new patient, actually look at them walking down the hallway as opposed to getting them straight onto the table and doing an examination in a supine or prone or sitting position without even looking at their normal gait and weight-bearing patterns.
Yep. They're all taught to look at it in school, but efficiencies of scale make that a difficult thing to do. So yeah, everybody should be doing that, but they don't.
Terry, if I can jump in with a couple of questions. First one relating to, again, the leg lengths and whatnot, and your either referral to go to X-ray or, as Maggie said, a pre-CT scan. When would you pull that out of the bag, so to speak? When would you include that in your case workup? Is there a certain timeline, or you've tried other things that then haven't worked and you're looking further along the scale? So that's one. On that, what about just a standing AP lumbar pelvis X-ray, barefoot, measure the top of the heights of the top of the femur? How does that sort of is that enough to base your leg length measurements off? And then second to that, a whole nother sort of topic is with orthotics and getting the person into them, what's your sort of clinical use of exercises, be it small foot exercises, be it calf, quad, whatever the exercise through the lower limb that you use, and then rechecking that gait analysis to see then if the orthotic or the need of the orthotic or the shape or however the orthotic set up needs to change? Or
Right.
is it once it's in and that's it?
Yeah. So let's start from the beginning. The first question is, when do you pull the trigger to do all this stuff? And
Or to do the X-ray, to specifically do a lower limb X-ray.
Right. So it kind of depends on how many you've seen and your level of expertise. But if I can correct the leg length discrepancy to pretty much even with treatment, I presume there's no anatomical portion. If the patient goes through, and if it's, I don't know, maybe we do a half a dozen adjustments and then we look. And if it's consistently there and it doesn't correct, then I'm looking anatomical and I'm asking the patient about previous traumas. And there have been a handful of patients who don't have a fracture, who do have an anatomical leg length, but they're really rare. So the people with a true anatomical leg length discrepancy almost always have a trauma. So that's that one. What was number two?
With orthotics, once you've got them to the stage or through your clinical workup, you've got the orthotics in, do you use exercise rehab stuff? I mean, you said you do, but what are those sort of exercises? The small foot, calf exercises, lower limb exercises. So what do you sort of typically use? I know it might be very case specific. And then secondly to that, once they've, say, got stuck into a good regime of exercises, do you then reevaluate the whole gait analysis and if that orthotic is still correct for them?
Yes. So in terms of the process, there's two ways to go. It used to be in the early days, and most people start like this. I assess the patient, I have my wonderments about their leg length. I start into a program of adjusting, rehab, looking at their posture, their sort of repetitive postures and movements, and try to sort the thing out. And if I can't, over 6 or 8 weeks, have them get substantially better, then fair enough. Then I'm going to go down another route, and I'm going to go down the orthotic route. What happens after you've done that 50 times is that you can anticipate that almost every time. So I see new patients every week of my life, and my new patient conversation goes normally as a new patient conversation, and somewhere in there, I'm asking them, can I get you to come back? We need to do a longer exam. We need to do a biomechanical exam because the underlying problem here is that you have a functional leg length discrepancy and we need to assess that. So I will oftentimes put people in orthotics from number go. Once they have orthotics, and the process is, and you know, sometime if you want to have a good chat with somebody about this, talk to Jason about it, because frankly, he's better at it than I am, because I refer people to him now all the time. But it's just a matter of looking at the patient's basic flexibility, starting there, a remedial flexibility program. Once they're good with that, how is their balance? Always, always, always in their orthotics. And what you'll find is that once they're in particularly if you've gone through 6 or 8 weeks of treatment and they just continue to have those asymmetries and tension and lots of tone and myofascial trigger points and all that stuff, after they've been in orthotics about 3 or 4 weeks, suddenly all that stuff just goes away. Because the reason for all the asymmetry and tension in the muscles is the asymmetrical foot function, which is creating medial Achilles tension and ITB tension and TFL tension and asymmetrical iliopsoas tension. Once you get the orthotic underneath them and they've got more balance in their body, now those muscles just relax and all the rehab stuff just simply starts to work. So a classic example of this is, again, in a yoga class, you see someone who's been in that yoga class for 2 years and they've got a big bunion on their right foot, which means their right foot overpronates more than their left. When they go into tree pose, when they're standing on their left foot, they get into the posture and they stay in it, no problem. When they do it on their right foot, they can't get into the posture and stay there. There's lots of imbalance because of what their foot is doing. We put orthotics underneath their foot. They get shoes that their yoga teacher says they can wear, and they wear their orthotics in class when they're doing standing postures, and now they can stand on both feet equally. The yoga didn't get them there, because the yoga's never going to get them there, because it's the bony architecture of that right foot that causes it to collapse. And you cannot restore that with strength. It's too much work for the soft tissues to get injured.
Okay.
Yeah, so my contention is you don't have to do all that stuff. If the patient needs orthotics, big ifs here. If they have asymmetric foot shape and function, if they get orthotics, all the soft tissue overwork is going to be diminished because of the presence of the orthotics. And then the rehab just goes on to, and the way you know if they're doing okay in terms of the rescan is because of their feedback. So typically patients are, in the first visit, patients oftentimes will cry. Oh my God, you're actually paying attention to me. You don't think I'm crazy. You don't think this pain I've had for 5 years is a fig Newton of my imagination. There's a reason for it, thank God. Yes, please. Then we put them in orthotics and they come back a month later, having had 8 or 10 adjustments. Oh my gosh, for the first time in 5 years, I went an entire day with no back pain. I'm so grateful. And then they come back a month later and they go, wow, I went 10 days with no back pain. Now they're mad. Why didn't the 2 physios and the 2 chiros and the osteopath and the surgeon figure this out? It's simple. That's a really typical response from the patients, because it's just like getting glasses. If someone needed glasses and they couldn't see, yes, you can give them extra. Some eye conditions will respond to exercises. Nobody's going to do them. You got to do them every day for the rest of your life. Same thing's true with what we do. That's just my opinion of that.
Okay, could I maybe put it another way? What if you've got a child presenting with something, they're still growing? At what point do you then, again, you made the decision to put them into an orthotic. At what point do you then scan, reassess the child and see, do they need a bigger orthotic purely because their foot's grown, or does it need to change because, again, their body shape through puberty has changed in whatever dimensions and that's got a different loading pattern? Or, hey, have they got to a point where their feet are, I don't know, balanced out? Or does anyone ever come out of orthotic, which I think you're going to say probably no from what you were saying before, but anyway.
Yeah, nope, sometimes. So the first part of the answer to that question is that in adults, if you're skeletally immature, if you need orthotics, you need orthotics, period. If you're a child and you're not skeletally mature, depending on how old you are, we might be able to get you to not have orthotics. So I have one personal case study. I put my nephew in orthotics when he was 8. When he was 16, he stopped wearing them without telling anybody. His mom noticed that his orthotics were in his closet. I said, if he doesn't complain, let him go. He's never worn orthotics since. Doesn't ever have a pain. So, and when do you put kids in orthotics? My youngest patient was 14 months old. If you want to stick around for a few minutes, I'll show you pictures, video of her. This kid was headed for surgery for sure. And 8 weeks later, she was running down the hall in my clinic. No, not at 8 weeks, 12 weeks. But I mean, massive difference. So in the early days, I used to say, I'm not going to put orthotics underneath the feet of kids until they're 5 or 6, until they can be responsible enough to keep them in their footwear and they got a little more foot growth, and you know, they're going to walk on their toes until they're 3 anyway, and blah, blah, blah. Until kids like this walk into your practice and you go, I got to do something. I got to do something. And we try and we get great results. It's non-invasive, it doesn't hurt them, and it's relatively cheap. So we try. Yeah.
Okay.
So, yep. Did we get there, or do you have another one? You asked a question about can you do an AP pelvis? And get
no, I guess it's more that if you're using all the, I think you've answered it, but if you're using all the rehab and exercise and various things, do scans change and therefore orthotics need to change along the way, or is the orthotic that you put in at any point, is that it, I guess? 90%
of the time, yes. Your premise that if someone is really compliant and they go through the rehab and there was a large component of their foot asymmetry that in some degree was contributed to just by muscle imbalance, then yes, they would need to be revisited. I've done about 4,000 pairs of orthotics, and I've remade less than 10 in adults. So it's really rare.
Okay, cool, thank you.
With regard to, can you look at an AP pelvis? Here's one, right? Can you guys see that?
Yep.
Where am I? Slideshow. Right? So this is a 61-year-old man. There's a whole thing on this, but this is just one slide from that. So his femoral head height, this is him standing. His femoral head height is 3.5 centimeters difference. Okay? His sacral ala is less than 1 centimeter, and the iliac crest is 1.7. Which one is it? You cannot use this to determine leg length because there's too much going on. The lumbar spine is moving, the SIJs are moving, the pelvis is tilting and rotating, it's flaring and going EX and IN, all of that's happening, so you can't tell. Most people would look at this x-ray without all those measurements and say that this person has a 3.5 centimeter short left leg, right? So, but that's not the case. And so what I'll do is I'll now show this to you, just because this one doesn't take long at all. So his complaint is hip and back pain, but he's also got a bit of a scoliosis. That's his x-ray. Previous trauma. So you got to get your rights and lefts here. He fractured his right femur, tibia, and fibula when a car hit him as a pedestrian. Post-operatively, he had a left hip replacement. So many years later, from having to walk on his left hip from his right side injury, he ended up with OA in his left hip and had his left hip replaced. And he's currently got bilateral hip and low back pain. The radiology findings are about, he's got a bunch of DJD in his lumbar spine. He's got a lot of facet syndrome in his spine, facet arthrosis, probably an old fracture at L1 from the car accident, which was missed, and postural changes. When you lay him on now, that same x-ray that showed 3.5 centimeters when standing at the femoral head heights, this is him lying down on his back, it's 2.5 centimeters. So now you've got a fourth number to indicate what the leg length is. So we did all that. That's just to give you the sense of his lateral. This guy's spine is pretty munted. Right, so now this is a Bucky that has a measurement stick on the back of it. So this is a long bone study. So now here's his left hip replacement. So this is an anterior view. This is the reading right patient's left. There's the left hip replacement. There's the fracture in his femur. They've taken the hardware. Here's the hardware left in from his tibia fracture. They took the hardware out of his fibula fracture. And you can see when he's standing up, that tibia is shorter than that one, full stop, right? And this femur is probably shorter, but how much, right? So you don't know until you measure. That's just a close-up of the knee. So that knee is starting to already lose space and get degenerative. So this is a reading of the x-rays, not all that important. What's important here is the measurement. So here's the individual measurements of the right and left femur, right and left tibia, the totals. There's actually only an anatomical length of 1 centimeter between his legs, right? So everybody would have put 2.5 or 3.5 or 1, and they would have gotten lucky at 1, right? And so the total discrepancy is 1, and we put him in orthotics because this was a combination. It's not either or often. If somebody has an anatomical leg length discrepancy, they probably also have a functional leg length discrepancy. So he got orthotics to balance the functional movement of his feet that was asymmetrical. Then we put a 5 millimeter lift through his entire foot, not underneath his heel. Heel lifts are only to be used with Achilles tendinopathy and always on both sides. You can use a heel lift with a patient that you suspect a tiny little anatomical leg length difference in of less than 5 millimeters. But beyond that, the heel lift eventually is going to do more harm than good. He had about 12 visits. This was actually a patient at the NZCC clinic, the student clinic. He had a great outcome. So when I met him, he was really struggling to work as a massage therapist. And after we got through with him, whatever that was, 6 weeks, he went back to work. So now there's that one. And then I'm just going to quickly show you Abby because she's really a trip. There she is. So this kid is awesome. Now I'll go back. Oh, right. So this is just static. So right, like stupid pes planus reverse. Like this kid just does not have arches. She's 14 months old in this picture. Sorry, 16. Her parents came in. The family has been seeing Sherry Brady Kay for years, and Sherry sent her over to me. And they're concerned about her feet, of course, and she's not standing or walking independently. So she is otherwise, her development is otherwise normal. She doesn't have delayed development otherwise. It's just her feet. The pediatrician, of course, says she'll grow out of it. They're not so sure about that. And dad has overpronating feet. So yes, she's got all these things. Now, here's the thing. Here's the fun part of this. This kid is 16 months old. She can't really talk to me. And she's been to see way too many doctors. So they go to put her on my table and she like almost started to cry and she's like, oh, right? And so I just did a foot massage. I just very gently started to massage her feet. And she finally relaxed. She laid down. She leaned back against the pillow. I worked on one foot for a little while. And then after a few minutes, she took her other foot, pushed my hands away from her foot and put the other foot in my hands. So she wouldn't do the other foot, which is great. Now, by that time, now I can check. Yes, she has a leg length discrepancy, much more difficult to tell in a toddler about what that's all about. But she did have a difference. And as I started to palpate, then she would pull away when I started to palpate. In the very typical places you would expect that foot to have palpatory tenderness, right at the insertion of her plantar fasciitis, right in the middle of her arch, all the way up her shin on the medial side. So she's got shin splints, she's got plantar fasciitis, she's got joint dysfunction, she's got inflammation. She's not happy. But all I did was evaluate her like that. Now this is, right? So I'm going to stop this for a second. So if you put her sister at the end of the hall with a toy and you give her one finger to hold on, she can walk down the hall. She physically can do it, but she refuses to stand up because it's bloody painful. No. So that's the same thing. Good job, Dad. And you can see how much worse the left is than the right, right? This is about what I found in our physical exam and what we did. When we can't really walk a toddler across a pressure plate, so I just put her foot in a foam box and gave the clinic a bucket load of information about her, and we made orthotics for her. Yep, I talked about that. There's her little, it's so cute, her little foam impressions. And so her parents decided to make the investment. We did the fitting 3 weeks later. Sherry Brady Kay did all the follow-ups, adjusted her feet and her ankles and her knees and her pelvis. And, you know, the kid was used to getting chiropractic care, so she loved that. And I told Sherry, I suspected she had an anterior talus and an inferior navicular and inferior uniform, and everything is just collapsed, and a medial calcaneus. So she checked and adjusted her. And so here she is, 7 weeks later. Now she's a little over 18 months old. Oops, sorry about that. There we go. Oh no, it's upside down. Damn, sorry guys. But anyway, so she's still a little off center. She's still learning basically how to walk, but she's willing. That's the take home here, is she's willing, right? And that left foot is much better. I think there's another one. Nope. Okay. And then this is a nice letter that I got back from her mom that basically said, now they have a healthy, happy kid who's running around the house, and she's happy to have me use the videos and blah, blah, blah. So that was a little pat on the back for me. And then now here she's 26 months old. So this is a year later, right? Right? So would her feet be that good a year later anyway? Somebody could make that argument. I like to think the orthotics made a huge difference.
Little micro movements in her feet are so different, aren't they? Wow.
Yeah. So she's had, I think, I don't know, several pairs, 4 or 5 pairs of orthotics. Because the answer to Rob's earlier question is the kids are going to outgrow the orthotics. And when they outgrow the orthotics, that's based on, it's about every 6 months, depending on their age. But basically, I just have the parents, like they do on the wall, where you measure the kid's height on the wall. You just take a piece of cardboard, put the kid's foot on the ground, and just draw a line at the front of the foot and at the heel, and measure the distance, and do that once a fortnight. And what you'll see is that at some point the foot goes boink, and now it's suddenly a centimeter longer, and that will always happen before they grow up. Right? But God gives you better feet before you get height, so you don't fall over. So when they get that little growth spurt, then they make an appointment, they come in, I make it, you know, the patients basically pay rack rate for the orthotics at the first instance, but for the kids thereafter, they get the orthotics super cheap, and I don't charge them for a rescan. That's just me. That's how I do it. So they pop in, they have their scan. We ordered because they could change. Yes, Rob, their feet can change because of growth, because they're functioning better, because they're getting adjusted, because they're getting more exercise. All those things can change their prescription. So I re-examine them. We do another scan. I send all the info to my lab. I have a chat with them, particularly with patients like this. And then they put another pair of orthotics through. The family pops in, 15 minutes, boom, 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 go get new shoes now. Everybody's sweet. So that's how that works. I get a great deal of joy out of that. And then what I'm putting out to the universe these days is that I want to, not that guy. I want to see, there we go. That's not it. That's not it. There we go. If I could see teenage boys all day long, they're great patients because of how they respond. Right, so 15-year-old boy, bilateral heel pain and right anterior knee pain with playing basketball and running. The exam reveals a scoliosis, which is what gets his parents' attention. So again, I'll summarize this for you. The dates are kind of important because it happened really fast. January 30th, he presents with his mom. These are his symptoms. He's clearly got plantar fasciitis. He's got a little infrapatellar tendonitis. It's not tracking, it's the infrapatellar tendon. And he has a functional leg length with a right long leg, which is causing a mild scoliosis. We didn't treat him the first visit, although now this patient had been a patient with one of my associates for about 3 months prior to this, and he wasn't getting better, so they sent him to see me. And more recently, he'd had really regular visits. The chiropractor said, look, we just have to see you more regularly, and that still didn't get him where they needed to be. We got him a pair of orthotics because teenage boys can just move them from their street shoes to their school shoes to their play shoes and all that stuff. And they work in his basketball shoes and all that good stuff. And then he came back for treatment for 3 weeks, or came back for fitting in 3 weeks. And then we saw him twice a week, I think, for 3 weeks. So this is before. So this is him standing barefoot in a room, and you can see an elevated right pelvis and a depressed right shoulder, front and back. You can even see the nipples on his chest. His whole rib cage is moving because of that curve in his spine. So that's him just standing there. Now that's after 6 weeks of regular chiropractic care.
Sorry, Sherry, can I just stop you there? I'm not sure if we're seeing your share screen at the moment.
Oh, that's unfortunate. That's my mistake then. We'll go there. Thank you for saying something. Why won't it let me share? There it is. Right. We'll go back. Thanks, Rob. Sorry about that, everybody. Right. So yeah, you just need to hear the first bit. So right here he is with all this asymmetry with an elevated right hip and a depressed right shoulder. And because of that, now in his case, there's a really small little left lumbar scoliotic curve here. And then he leans long back to the left, and then he's got a little curve back that way, and then his head tilts back. I didn't get that, which is, I didn't take pictures of his head because he's a youth, and if you don't want to put anything in public with their face on it. This is a scan of his static standing, so this is assessing balance, and he's actually pretty good. 51, 49, front to back, 44, 56. It's a little heavy on his left foot, nothing too crazy, but no toes. Right? So he's holding his toes up. That's another lecture, but the one sentence deal here is you hold your toes up when you're trying to hold your arch up. Because when you contract your extensor digitorum longus tendon in the anterior shin, the tendons go underneath the retinaculum on the dorsum of the foot. And when the extensor digitorum longus tendon or muscle fires, the tendons get tight and they lift the arch via the transverse, or via the retinaculum that goes transversely over the dorsum of the foot. That's why people get anterior shin splints, because they're holding their toes up when they walk. There's his scan, landing on the outside of his heel, putting a lot of pressure in his heel, and ending up going off his second toe. That's not horrible, but he's compensating, putting all the pressure on the lateral side. On his right side, he's more in the center here, but this foot is a lot more dysfunctional. He flies, the dots indicate speed, so he goes really fast through his heel. He collapses in early mid stance into his medial arch, and then this line, which should come up more along his third toe, is shifted to the inside of his toe, so he's overpronating more on that side. There's the numbers, which I'm not going to take the time to go into now, and a bunch of written findings, which I'm not going to take the time to go into now. So January 30th is when the exam was done. February 21st, 3 weeks later, he gets his orthotics. They've been custom made in Canada, and we start the treatment plan. So this is 3 weeks later, right? Now, he's not barefoot. He's in his shoes with orthotics, but his posture is massively better. So from my perspective, this is a significant change in this young man's life. Because if I fast forward 40 years or 50 years, if he doesn't do this, he's got OA in his low back, he's got OA in one of his hips, he's got chronic calf muscle tightness, he can't play basketball, he can't stay fit, he can't run. And so he ends up, like many people, doing biathlons, cycling and swimming because he can't run, because that messes him all up. March 30th. So now we're 6 weeks later, doing well, no pains. The knee is resolved, and the arch is resolved. His heels are resolved. He can run long distances without heel pain or knee pain. He took a fall on his coccyx, so we're treating him for that. The foot exam was unremarkable. He didn't have any signs or symptoms. No leg length inequality. This is the thing that really will blow your mind. When you get the right pair of orthotics with a patient that attends to the asymmetry in their body, they will show up for every wellness visit with legs the same length, with a few exceptions. And that's when they sit in a funky car, fall down, something happens to blow their pelvis out. And then they go, and then they get an adjustment or two, and they're sorted because they go back to being in balance. It's really fun. I can't see Jason, but I'm sure he's nodding his head. And then he came back every 4 weeks because he knows he makes his basketball better. So that's him. So any more questions about that? Oh, there's still about 10 of you left. Good on you.
Are we talking a bit about plantar fasciitis today?
Yes. So this plantar fasciitis is really straightforward. If the patient has never had any foot arch or heel pain, and they go tramping for their first time in October because the weather clears up, and they do a lot of hills, they may well end up with a little plantar fasciitis from being in their boots for the first time, from doing lots of downhill, where you're going to have lots of arch collapse, and they may have that overuse done. But what's interesting is they won't come in with the same amount of pain in both feet. They'll have plantar fasciitis in one foot. Both feet went on the same tramp in the same shoes. Why is one foot worse than the other? Because their biomechanics are different. And the biomechanical faults can be really subtle, or they can be really gross. And so with that patient, I would just adjust them, do some soft tissue work, teach them some stretching exercises. If they come right in, 10 days or 2 weeks, fantastic. If they don't, here's some over-the-counter orthotics. Just give your foot a little support for 6 or 8 weeks, and it should all just go away and they resolve. Yeah. That's the textbook way to manage that. But if that doesn't happen, and it recurs, normally what happens is they get better because you sit on them and you make them rest. So if they rest and do the therapy and do all the things they're supposed to do, they get better. Fantastic. When they go back to their work or activity, if their symptoms come back, then that's probably the requirement is now for something more sophisticated, so that the orthotic underneath the symptomatic foot is different than the orthotic underneath the asymptomatic foot. Wow, I got a massive rainbow. Sorry, that was just got me. Does that make sense, Colin?
Yep.
Yep.
We haven't talked much about actually adjusting the foot in the process of trying to rehabilitate pronation and other issues.
Yep. So
I personally had I'm a bit weak on the adjustments because I think I can adjust something, and as soon as they stand up, what's going to hold it all there? So, you know, I am weak on my appreciation of how effective some of these adjustments are supposed to be. What's your experience and what's your attitude towards the actually adjusting all these bones in the foot?
Yeah, again, the same thing, the same principle applies. If this is a new, fresh, first-time injury, and you've got a subluxated foot, and you adjust the foot, the patient will probably respond really well. If they don't, and it keeps getting subluxated, and they could keep having those findings in their feet, and they still have the symptoms, then the adjusting by itself is a waste of time, because it's not going to get them there ultimately. So you have to give them something else, either a temporary orthotic over the counter, just to give their soft tissues a little bit of a rest while everything heals, or eventually a full-blown custom orthotic. But that actually leads on to another comment that I wanted to make before everybody goes, and I wish I'd said this before. I'll send an email out. In thinking about this presentation, there is so much more to sort of go through. Like, it would be really fun to hang out for 3 or 4 hours and just look at extremity adjusting. So how many of you that I can see by show of hands have what I call an X-drop or a speeder board that you use for feet? Great, about half of you, fantastic. So if you don't have one, I wrote a manual for the NZCC for the students. So I'd prefer that if you want that, you do write to me by email and ask me for that manual. It's a PowerPoint presentation that I can print into PDF. And it's a fantastic manual for, like, oh God, how do I adjust an inferior cuboid, right? And so, because there's some subtle things about how you set that up to make it more successful. And the X-drop means that you're not yanking on the patient so much. I'm not a big fan of grabbing the dorsum of the patient's foot and yanking on there, because all you're going to move is their second cuneiform, because that's the only bone in their foot that's going to go dorsal. And it's because that bone is shaped like this. So the second cuneiform is V-shaped like this, and the medial and lateral are V-shaped the other way. So when you get pressure through the midfoot, that second cuneiform goes superior, which is why that adjustment is so popular and so easy, right? Drop it back in, fantastic. And the patient thinks you're a hero because you can make that noise. And oftentimes, as you probably know, the talus kind of comes away from the tibia at the same time. And if you pull really hard, the tibia and the femur come apart, and the femur and the acetabulum come apart. And you've just distracted every joint in the body. You don't necessarily want to do that. So there's other ways to do that using this book. So on the heels of this conversation, when the dust settles from COVID-19 and people are starting to make a living again, I'm thinking sort of late in the winter or early in the spring, doing another longer, maybe a 3-hour webinar that will take breaks in, that will cover more of the clinical aspects of this in a little more detail. And then sometime after that, I don't know if we can do this virtually or not, but maybe put some people in a room and put a camera and do some adjusting and do some of this assessment. Because if you can get with other people, and because all of you are going to have problems, which is why we all got into this business, right? And so when you can assess this and do hands-on, and it's really nice, particularly like in a sports setting, where you're going to look at lots of people in a short period of time. Dedicate a day, even in your practice when you're going to have a busy day, commit yourself to leg length checks before and after treatment. It will blow your mind how often that's not resolving things. And so it's simple things like that. And when you start to see repeatedly how chronic that common this is, Mike, someday again, when I've got research time, I'm going to go set up in a mall, and I'm going to randomly pick people out of the mall and say, for $15, lay down here. I want to check you out. We're not going to do anything to you, but look. And then we're going to take a survey of what your symptoms are, so that then I can statistically link that. Because what I'm going to find is people who have recurring chronic low back pain, who don't have a disc, don't have a fracture, don't have pathology per se, a huge percentage of them are going to have leg length discrepancies. 80–90% of the people with recurring low back pain are going to have a functional leg length discrepancy and maybe anatomical. If I can produce those sort of numbers, then I can compel practitioners to look at that more carefully. And what I really want to do is sit in a room with 200 orthopedic surgeons and say, guys, why is it that a 68-year-old woman presents to you with one hip that's shot, full of OA, and the other one's getting there? She never played rugby. She never fell off horses or motorcycles. She's never had a trauma to that hip. Why is one hip so full of OA? This is why. And so when I see grandma and I tell her that story, she gets her daughter in, who gets her daughter in. And now we get everybody sorted so that the granddaughter doesn't end up with the OA in her hip like her grandmother. And you save the patient a hip replacement. You save the medical system thousands and thousands of dollars, and you save your patient decades of pain. So that's why you look at this stuff, because of big picture. Yeah. And with the athletes, the performance enhancement is amazing. As a matter of fact, quick story. Somebody once asked me, this is a golfer, because I was doing a talk at the Belfry for the British PGA organization. And they said, so if I have a card, if I'm playing professional golf, if I use orthotics, is that cheating? Is that performance enhancement? I said, I don't know. So I wrote to the Royal and Ancient, and they wrote back. And they said, yep, we've had this question before. And the answer is, if the golfer has a diagnosed condition for which they got custom orthotics, fair game. It's just like wearing an elbow strap or something else. However, if they don't have a diagnosed condition and they have orthotics and they're using them, they're considered to be performance enhancement. And so they can't wear them. So that's another study I want to do. Test people's drive, good golfers, measure their drives, go away, put them in orthotics, no coaching, no golf for the 8 weeks that it would take to get the orthotics and get them underneath them and get them adapted to them. Then go out and have them hit balls again. I know they're going to have 30 meters more on their drive. I'm sure of that. Because I watch it in my patients. They're suddenly, instead of pulling out, their 4-iron, now they're pulling out their 7-iron for their next shot because they're that much closer to the hole.
So that's where I would argue that the pattern is coming out of the pelvis, and particularly the abdominal muscles with the rotation of the swing.
Yep. In a pro golfer, yes. In your average golfer who golfs twice a month, not so much.
Potentially. Again, it depends on their other habits. But
yes,
and a lot of the golfers used to carry bags. And the way the carry bags are set up, you always have to pick it up off your right arm. Yep. And that's also, if you're right-handed, the most dominant muscle that's used on the rotation of the swing.
Yep.
So for golfers, I see a huge amount of short legs on the right, or positive Deerfields, coming out of a muscle imbalance in the right abdominals,
yep.
which will then contralaterally affect their left knee and foot.
Yep. And those patients respond really well to what you do. Yeah.
Absolutely.
Yeah, of course they do.
But the orthotic would stabilize their foot, but it wouldn't fix the abdominal pattern.
Oh, sure it would. Because part of that abdominal pattern, part of it is just every step they take, rotating asymmetrically. Then you're putting on top of that a golf swing and carrying a bag. So, which is why there will be some patients that you do what you do with them, and it gets them part way. If they start being less compliant and they stop seeing you as much and their symptoms come back, put those people in orthotics, then they don't have to spend, be in your office once a week and be doing all the exercises they don't want to do every day, because you take out the component of it, because it's not this or that. It's a combination.
What I'm saying is that that's stabilizing. It's kind of like I hate to use this word, but it's almost a Band-Aid, isn't it?
The stabilizing of
the orthotic, what the orthotic would do.
No, because the presumption is that if they need an orthotic, they in fact have asymmetry in their tarsal bone shape and therefore permanent dysfunction in how their feet function. And so that's the only circumstance in which you put orthotics underneath them.
Right. So then we're talking, I guess, apples and oranges there.
Yeah, they're completely different things, but they oftentimes occur together. So yes, they're apples and oranges, but all the fruits in the same bowl.
Could happen together.
Yeah. Yeah, probably does.
It's a challenging one because you can see it from both angles.
And at the end of the day, you just have to choose what's best for your patient.
Right. I do
And
see
it's-
that though. If I see with what I'm working through, if I'm not getting stability, then I'm definitely going to be looking at the feet. And that's why I
Yep.
signed in today, was particularly to see how you're addressing that.
Perfect. Yep. And then what I would encourage you to do is put the time and effort in to learn how to do it yourself, so that you're not depending on a podiatrist or a physio or an osteo or any other. The truth of the matter is, from an economic perspective, you're probably going to hesitate to send a patient to another chiropractor to get orthotics for fear of losing the patient to the chiropractor. Most of us are pretty confident we don't have that problem, but a lot of practitioners feel that way. But yeah, if you're referring it out, you've got to really have a really clear idea of what they're doing.
Absolutely.
Yeah.
I'm going to sign out. Thank you very much. I enjoyed it a lot.
Very welcome.
Cheers.
All right. Thanks, guys. So you'll be hearing from me about future seminars, and I'll send you lots of stuff by email with attachments for documents and stuff that I think you might like to see. And I'll send a PDF of the presentation as well.
You got time for 2 questions?
Absolutely.
Okay. And one of our podiatrists showed us the Lodi taping technique
Yes.
she sometimes uses to see if she thinks she needs to do orthotics. Have you used it? Do you find it useful? Is it?
I've done probably 1,000 Lodi tape jobs in my life.
Yeah.
Unless you're really good at it, they're pretty uncomfortable for the patient.
Okay.
It usually ruins their skin. So it's not a long-term solution by any means. It's an interesting way to see if they need orthotics. But
Yeah.
if you think their foot is bad enough that they need Lodi tape job, they need orthotics,
Yeah. Okay.
right?
Yeah.
It's as simple as that.
My other question was, have you got any superstar answers for kids that walk on toes?
How old is the kid?
Oh, it's not a specific case. Just over time, I've had quite a few of them come my way, and I kind of go, "Oh no,"
Right.
because it's quite.
Yep.
I find it a tricky one.
It's tricky and it's common. So it really depends on the age of the kid. So first of all, they're supposed to walk on their toes until they're about 3.
Mm-hmm.
So you don't worry about it. If they're still walking on their toes when they're 5, then then they've got, for some reason, they've got contracture in their posterior calf muscles.
Mm-hmm.
So the first thing you do is to find out, do they have the flexibility if you do enough? So what you do is you adjust their foot and their knee and their hip and their spine, and you get them neurologically and biomechanically as mobile as you can get them. And then you massage the bejeebies out of their posterior calf and their foot. You spend a good half hour, 45 minutes with them, and you really work on their flexibility. And can you get them non-weight bearing to dorsiflex their foot better, meaning they have the available flexibility.
Mm-hmm.
And then you have them walk and you talk them through, this is what I want you to do. I want you to try really hard to strike your heel on the ground and roll through your foot, strike your heel, and you talk them through it. Most of them, you can get them to do that because what they're doing is habit. The reason it's a habit is because their brain doesn't want a heel strike because for them, it's an inefficient way to absorb shock.
Okay.
Right? So if they're heel striking the ground and they're massively overpronating in their rear foot, they're going to stop doing that. And they're going to go to their toe. It's kind of like the pose running thing, right? But if you're 4-foot landing when you're walking or running, yes, you get flexibility out of your calf muscles, but that's not their primary job. Their primary job is posture and propulsion, not deceleration, right? So if you can get the flexibility, it's there, great. Because one of the other possibilities is they have really mild CP. So that's one of the findings in really mild CP is these contractions. So my nephew, what's his name? Oh, the other one, Trey, baseball player, pitcher, really good one. He's like 6'4", really good baseball pitcher. But he can't play anywhere else in the field, and he does not a great batter because he can't get around the bases fast enough because he can't run really because of a very mild form of CP for him. So we put him in orthotics with a little bit of a heel lift. He wears basketball shoes all the time, and he heel strikes and he walks normally, and he's happy as Larry. But his left foot is way worse than his right foot, and you can see that in the flexibility. So part of it's the CP, and part of it is just contraction from walking like that as a child.
The 2 particular cases I'm thinking of, one is now, and I saw them when they were younger, but I know the families. So one is 11 and one is 6 now, I think. And
Right.
I did do that approach, and I just didn't get a result. And I know they can do it. And they're both of them. I'd say the thing that is common with them is pretty symmetrical. They do it. One of them in particular, we know them socially, so I watch him. If he's got stuff going on, I suspect there's possibly an emotional component too. His dad, for example, had a very bad car accident, and it all got worse. And I said to Mum, he said, "Oh shit, I know, it's all the time now." So I guess it's multifactorial.
Yes.
Isn't it?
And you might not get to point a finger at what the problem is, but what you've ended up with is posterior calf contracture. So try orthotics, right?
Yeah. Okay.
You know, put the kids in orthotics with a little bit of a heel lift. And because at the end of the day, if you're not going to get that flexibility out, just give them a little bit of a heel in their shoes and in their orthotics, and they'll do much better.
Okay.
The challenge there is that when you do that and you create that fix, and they're in balance and they're good when they're in their shoes at school and when they're in sports and all the rest of it. It's when they've been resting all weekend and they suddenly sprint barefoot because they're barefoot in the summer on the grass, and they oftentimes will tear an Achilles. So they've got to be really cautious about standing up from a cold sit and sprinting.
Okay.
That's true of almost everybody. Certainly that's true of me. But for them in particular as kids, they can't get away with it like most kids can.
With one of them we'd tried, and I forget the name of the shoe now, but it was a really rigid shoe. But having read your articles that you sent through to us as well, I understand why we went to that point, because we'd all exhausted all other ideas that we had. But to try to stop them being, or one particular chap, stop them trying to do that toe positioning, but it doesn't really stop it, does it? Because there's still enough give in a shoe. And of course, as you're saying, for all the proprioceptive reasons as well, you need the mobility, don't you, for the functioning of the arches.
Yep. So you want to, in the kids, you want to retain as much mobility as you can with adjusting and flexibility. And the difficulty is when you get a 6-year-old or a 10-year-old or even worse, a 13-year-old. Okay, now I want you to do these stretches twice a day for 20 minutes. There has to be a big incentive for that because they just won't do it.
Xbox could be the answer.
Yes, right. That's parental control.
Yeah, I'll leave that to them.
Yes.
Thanks.
Anybody else? All good. Listen, thanks for hanging out. Really happy that everybody came. Really happy there were so many here. Good to get, to have that email blast out to everybody, because that gives Rob and I a chance to talk about, Sports Chiropractic New Zealand. And hopefully we'll get more people involved. I'm at the other end of my career, so I'm not that keen to go stand around at a squash tournament as I once was. But, oh, by the way, I went to that squash tournament and I put in orthotics because he was having anterior shin pain on his right side, because a squash player does that on their right foot thousands of times. And he was getting this perpetual shin splints thing. And I'll tell you a great story. So I got there early in the morning, got set up. And I'm sitting there. I don't know Paul Cole because I don't follow squash, right? But he just walks up to me and starts talking to me, and I can tell he knows what he's talking about. So I figured out who he was and what was going on, and his comment was, "Wow, I can't believe you're here. I come to New Zealand and there's almost never any decent sports medicine. So I'm really happy you're here, and I'll tell everybody else." Because he's used to, he lives in Amsterdam, so he trains in Europe. And then he goes to America to go to competitions in both Europe and America. And he comes home. He's from, I think he's from Hokitika. And so he comes home and can't get the sports medicine he needs. So he was really grateful, and it was really nice to hear that.
Cool. Just to follow on from that, thank you again to all those people in the past that have volunteered to events for sports chiropractic. We've had some good results for individual clients that have sort of, we've met them through those events and things have gone on. Thank you particularly to Colin. You're usually pretty much a stalwart at these events, and Sherry and whatnot. In terms of, Sports Chiropractic New Zealand, it's stories like this from a few people that have then also got back to their federations and whatnot, and we've now been able to develop some relationships with the federation. Squash New Zealand is one of them. They were really keen to have us all involved at events going forward. Obviously, coronavirus has thrown a spanner in the works on that, so we're getting back to it. So not to take up too much more time, thank you for everyone attending. Those people that aren't part of the group, part of the fee that you're paying is going to help us do just general admin bits and pieces and get posters and tapes and all sorts of just the general background boring stuff to be able to do more of these events. Again, most of this is all voluntary work from the people in the group and whatnot. So yeah, again, another shout out on if you want to become members, you're more than welcome to. All the info's on the NZCA website. We've got more webinars coming up. We'll probably go more of just general email blasts like you get through Patricia and whatnot. So look out for them in the future. But I've got to go. Thank you everyone else for attending and have a great afternoon. Cheers.
Cool.
Thank you, Rob. Thank you, Cherie.
Yeah, thank you,
You're very
Sheree.
welcome. You're
Very well
welcome.
done. Very professional.
Thank you. Stay safe.
Right.
Be well.
Okay.
Appreciate all
Bye-bye,
that.
Maggie.
Bye.
Yeah, Margie,
See you
take care.
later.
It's just what the doctor ordered as well. Thank you.
Good. 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 Good.
Bye-bye,
Bye.
Andrea.
Bye. Good to meet you.
You too.